everyone, and thank you for coming tonight. So anyways, really excited to do this kind of cram session, high yield critical care review. Yeah, I took my critical care boards twice already, not trying to age me already. So the last time I took it was only about, oh my God, 2 years ago. So I feel like I'm in the trenches with you folks. And I got to tell you that, I know everyone's going to do great, whether you're recertifying or certifying. So what I did was I kind of picked a couple of questions I felt were like those, wow, are they really going there? And I really want to take some time to break it down because I know when I take my boards, I love to do things that are both practical for getting a good score and to help patient care. So I really wanted to talk about this question. This is a 52-year-old gentleman. He returned to the United States after a business assignment in Asia. Okay, where does this coming from? He was there for half a year, and then he goes to the emergency department with confusion and severe back pain. So this combination, going to the ED, this can't be good. So the patient's medical history is significant for recurrent uric acid, kidney stones. So let's go back to the first line. If you're getting severe back pain, you have recurrent kidney stones, what are they worried about? Pyelonephritis, hydronephrosis. Oh my God. So, and if you're having confusion, like what shock kind of goes with that? Well, any shock, but definitely sepsis. So already this isn't sounding good for this guy. So, and he's had these recurrent stones over the past 5 years. Around 8 months ago, the patient had lithotripsy, probably because the stone was so big, to address the obstruction. And that obstruction definitely was associated with hydro. And at that time, he developed urosepsis. So the etiological agent of that episode was Pseudomonas, and it was resistant to, fluoroquinolones. And, let's go back to some basics. So how do fluoroquinolones work? Well, they're protein synthesis inhibitors. Yes, they love to inhibit one of my favorite enzymes out there called DNA gyrase, otherwise known as topoisomerase. And it was also resistant to a third-generation cephalosporin. So what third-generation cephalosporin covers Pseudomonas? And the answer is ceftazidime, and it's also resistant to meropenem. So if you got a gram-negative that's resistant to meropenem, oh boy, God, now you're really worried about a lot of resistance because 3 letters jump to mind: CRE, carbapenem-resistant enterobaciae. And if you're going to be resistant to cephalosporins, oh boy, 4 letters jump to mind. No, not those 4 letters, but ESBL, extended spectrum beta-lactamases. He's not doing good. So patient has been on suppressive antibiotic therapy with ciprofloxacin. On exam, he appears acutely ill. He's febrile. His blood pressure is low. And they gave him fluid resuscitation. They gave him 3 liters of lactated ringers. And you know what? He didn't respond. They do a UA, as you should. There's numerous WBCs, white cell casts. And of course, you always want to do a gram stain to see, what are we playing with? Gram positive, gram negative. And what a surprise, it's gram negative bacteria. Based on these epidemiological considerations, what do I mean? Patient was in Asia for half a year. He has resistance to cephalosporins and carbapenems. For resistant pathogens and severity of this patient's clinical presentation, confusion, hypotension, what antibiotic would most likely cover all the clinical pathogens for which he is at risk for? So I'm looking at this and I'm like, are you kidding me? Is this going to be on my critical care board exams? The answer is yes. And I felt a little blown away too. I'm like, is this even English? What do we have here? We have some ceftolozane, tazobactam. I guess Zosyn's familiar. We're on some meropenem, vabobactam. We're on some Cefiderocol. And okay, another one jumps to mind, linezolid. So, I'm looking at these and I'll tell you one thing that for me, the answer doesn't just jump out at me. Which one can I say I'm probably not going to be worried about as much? It's definitely going to be, I'm not going to pick linezolid. Why? Because that gram stain is always so important. Can you have gram-positive bugs in the urine? The answer is definitely. Can you say Enterococcus faecium, or fecalis? And sure, you definitely will have a positive gram stain. But we have gram-negative bugs, so I don't think I'll be needing this gram-positive coverage. So which one of these is going to be the right answer? And the answer is, let's talk about it. The whole point of this question. So to pick the right answer, we really got to go back to the basics. And yes, I did put this slide up there. It does say prokaryotes and eukaryotes. So you got to understand, what are we and what are bacteria? So everyone, what am I? That's right. I'm a eukaryote, while bacteria are prokaryotes. So what really separates a eukaryote from prokaryotes is going to be those membrane-bound organelles. So prokaryotes don't have any. They don't have a nucleus. They don't have a Golgi apparatus, a mitochondria of any of these things. But we do, and of course, being eukaryotes, what is the most important thing I have inside my cell is going to be the nucleus. And when we talk about the name eukaryote, U means true, and karyote means nucleus, true nucleus. So why am I even bringing this up? Because it really shows why when we take antibiotics, they can kill bacteria and not us. Because prokaryotes are just going to be basically just a bunch of cytoplasm. So when we talk about the dogma of how antibiotics work, well, when we talk about humans or bacteria or viruses, it really comes down to DNA can replicate. DNA can undergo transcription, where we make, things like messenger RNA, which is a temporary copy of the DNA. And you can undergo translation, where you take that messenger RNA and you can make protein. So these are going to be ways that antibiotics are going to be working. So when we talk about that RNA here, I know I just put the word RNA here. Remember, there are 3 types of RNA, and this is why it's going to be very important I'm mentioning this. We mentioned messenger RNA, just that temporary copy, but ribosomal RNA, when we talk about bacteria, you can just imagine huge cytoplasm with tons and tons and tons of ribosomes just in that cytoplasm. And of course, when you want to make that protein, these transfer RNAs bring in amino acids to make that protein. So when we talk about these prokaryotes, this is going to be a nice picture over here, that you're going to see lots and lots and lots of what? Cytoplasm. And all these little dots here, tons and tons of dots, are going to be what? Ribosomes. And we're going to break down, the structure of the bacteria when we talk about cell wall and cell membrane in one moment. But I really wanted to show you how many ribosomes are just hanging out in the cytoplasm, and there are no membrane-bound organelles. All you have in the cytoplasm is what? The DNA right there. So when we talk about these, prokaryotes, bacteria, and I said ribosomes are going to be the ones that are going to be translating that messenger RNA, that in prokaryotes, of course, we have what's called the 70S unit. It's made up of the 50S, the big one, which really brings in the transfer RNA, and the small one, which actually is going to take the messenger RNA and make the protein. So with that being said, now that you understand the beginning, why is the gram stain so important on any board exam, including the critical care boards? Because it's really going to tell you, number one, what are we trying to cover? And number two, it really makes you appreciate the word resistance. So when we talk about the critical care boards, what are the hottest topics in critical care now? Are resistant gram-negative bacteria. That's a huge thing right now. So when we talk about, in general, why is there a lot more resistance when we talk about gram-negatives versus gram-positives, is it really comes down to the basics. It really comes down to, what makes a gram-negative negative and positive positive? And it's more than just the gram stain. Of course, if you're gram-positive, you're going to have a little purple color to it. If you're gram-negative, you're going to be kind of like that pinkish red. But it really comes down to the cell wall. So when you tell me what is probably one of the most common categories of antibiotics that we use for bacteria, it's got to be beta-lactam drugs. And so when we talk about beta-lactam drugs, let's list a couple of them. Penicillins, cephalosporins, carbapenems, and what are they attacking is the cell wall. So when we talk about gram-positive bacteria, look at their cell wall. It's in yellow here. It's huge. You have a huge target for these antibiotic categories, these beta-lactams. Well, when we talk about gram-negatives, the cell wall itself is actually really small, a very small target. Now, on top of that, when we talk about bacteria, gram-positives or negatives, what's going to be above and below the cell wall is called the cell membrane. So people always ask me, what's the difference between a membrane and a wall? Well, the cell membrane is semi-permeable, but the cell wall is pretty impermeable. So look at this gram-negative that's going to be on the right. You got that cell membrane above and below the cell wall. And what is this layer up here? It's called a capsule. So gram-positives and gram-negatives could have capsules, but look at all the defenses a gram-negative has just to begin with. So, I know when we talk about capsules, we always, I know back in USMLE Step 1 days, there were little mnemonics we remember of who has capsules and who don't. I think that Klebsiella has a capsule, Strep pneumo has a capsule, Neisseria has a capsule. There's all these different ways we kind of remember this. But with this being said, what are we talking about today? Gram negatives. So now we know what really separates gram negatives from gram positives. So when we talk about the two main categories of antibiotics you need to know for the critical care boards, I put them in stuff that attacks the cell wall. So they're going to be these beta-lactams. We said penicillins, cephalosporins, and carbapenems. But what other antibiotics can also attack the cell wall? Of course, vancomycin and something called azotrianam. We don't use it that common. It's a monobactam we use for people who are somewhat penicillin allergic. And then the other way is going to be called bacterial protein synthesis inhibitors. And that's where we went back to that initial dogma right here, where we said, hey, don't forget this. That's how our antibiotics are going to work. So when we talk about what's going to inhibit bacterial protein synthesis, especially when we focus on gram negatives, think about aminoglycosides, but we don't really use them. Why? It's because, number one, toxicities. And who can tell me the two toxicities of aminoglycosides? Things like gentamicin and amikacin and tobramycin. Yeah, of course, renal toxicity and ototoxicity. And then of course there's macrolides, there's tetracyclines. Please God, no one pick chloramphenicol for your boards. That's always the wrong answer. And of course, our gram-positive coverage, linezolid, these are going to inhibit bacterial protein synthesis. So one thing I wanted to mention, which is going to be great for the board exams, is, well, how do bacteria get resistance? So if you're going to be a gram positive, usually when we talk about beta-lactam drugs, gram positives get resistance because of mutating the penicillin binding proteins. So all beta-lactams, whether they're cephalosporins or carbapenems, they bind to these penicillin binding proteins, and from there they can damage the cell wall. Gram negatives, however, they usually get resistance by making what they call beta-lactamases. So by making these beta-lactamases, they break down the beta-lactams. So gram negatives, like the question we're talking about now, are probably going to have resistance because of they have these beta-lactamases. So when we talk about beta-lactamase inhibitors, so all those drugs you saw over there most of them had a core drug attached to a beta-lactamase inhibitor. So the classic ones are things like tazobactam, clavonic acid, sublactam, and these are kind of like what we refer to as suicide substrates, meaning that they're attached to an antibiotic, and what happens is the bacteria destroys the tazobactam, the clavonic acid, the sublactam, and the core drug does the killing. So it's like a suicide substrate. But there are newer generations of these beta-lactamase inhibitors, avibactam, relbactam, vabobactam, and they don't even contain a beta-lactam ring. So we kind of call them these non-beta-lactam, beta-lactamase inhibitors. And when they do their killing, it's irreversible. And because it's irreversible, they got FDA approval for really resistant gram-negative bugs, such as ESBL and CRE, just to mention that. So why am I even talking about this? I'm sure someone listening today is like, oh my God, what is this slide? But it's getting confusing. So rounds in the ICU, what's a Fetrosia? What's a Vabomere? What's a Zerbaxa? What's a Ricarbio? Like, what happened to the olden days? Where's my Cefepime and Augmentin? So there are so many combinations out there. And what are these new drugs for? Resistant gram-negative bugs. So that's why I put this question here. So on top of this being confusing, there's a lot of overlap. And what is the niche? So even when we talk about the drugs in this question, things like Vabomere or Zerbaxa, that sure, they definitely have their niche, and we're going to talk about that, but there's a lot of overlap. So, Avacaz can have a little pseudomonal coverage, but same as Zerbaxa. Can Zerbaxa cover some ESBL? It does, but it's not really an ESBL drug. So because of all these things, it's very confusing. And now there's questions like this on the boards. So to really appreciate these drugs and how do we get here, we really have to go back and just kind of go to the basics and see how we kind of progressed. So when we talk about beta-lactams, it really comes down to the penicillin story. So when we talk about penicillin, number one, The year is the 1940s. And in the 1940s, there was a very famous world war. I mean, who could tell me what world war was in the 1940s? That's right. It was World War II. And during that war, there was really bad infections, a lot of bad skin infections. And when you have a lot of skin infections, of course, you worry about gram-positive bugs. So, of course, penicillin that was discovered by Alexander Fleming, was one of the main drugs that we were using at the time. And we had our penicillin. Of course, the minute we started using it, we get what? Resistance. And how did they gain resistance? They're modifying that penicillin binding protein. So we came up with semi-synthetic penicillins, things like oxacillin or napacillin. And of course, what happened was there's something called a MEK-A gene that was one of the mutations, and it gave us MRSA. But all this was for gram-positive coverage. But we wanted to have some gram-negative coverage. So we came up with the aminopenicillins, things like ampicillin, things like amoxicillin. But those are only gram-negative easy bugs. So what is a gram-negative easy bug? Will be something like E. coli, But we wanted to go to those gram-negative difficult bugs, And what's that difficult gram-negative we worry about? Pseudomonas. So what did we come up with? Extended spectrum penicillins. And the classic one out there is piperacillin. But what do we know, everyone, when we talk about gram negatives? How did they get their resistance? Yeah, through these beta-lactamases. So we wanted to come up with beta-lactamase inhibitors so our gram negative, core drugs could have more oomph to them when they want to combat things like Pseudomonas. So we came up with all these first generation beta-lactamase inhibitors, flavonic acid, sublactam, and of course, tazobactam. And we took the piperacillin, combined it with tazobactam, and we got Zosyn. And we definitely know Zosyn, broad spectrum antibiotic, that definitely covers what? Pseudomonas. But of course, we weren't happy just having penicillins out there. We came up with cephalosporins, which is another beta-lactam drug. So when we talk about cephalosporins, it all comes down to these generations, and it's kind of confusing sometimes because you got to memorize a lot. But I think most of us agree that when we talk about cephalosporins, the earlier generations give you more gram positive. And as you go up in the generations, you get a lot more gram negative. So, we have our first generation cephalosporins, things like Keflex, things like Ancef. And then we went to our second generations. One of them that jumps to mind is cefotetan. Why? Because it had a little, anaerobic coverage. And then we went to our third generations, and that's when we got our first anti-pseudomonal cephalosporin, which I mentioned already was what? Ceftazidime. Of course, we have ceftriaxone, our workhorse for community-acquired pneumonias. Then we went over to the fourth generations. And I'm sure many people listening today have their workhorse in their ICU, which is what? Cefepime. That definitely covers what? Pseudomonas. So now we have two anti-pseudomonal cephalosporins. But the story doesn't stop there. There's actually fifth generation cephalosporins, and two of them that jump out at me. One is called ceftaroline, which really kind of is more niche to MRSA, but the other one is ceftolozane. And not only does ceftolozane cover Pseudomonas, it got combined with tazobactam, and now we have the brand name Zerbaxa. And it's a really, really good drug when we talk about, addressing Pseudomonas. So with that being said, let's take it to the gram-negative bug. And, how do you get resistance? So this is going to be a more detailed view of a gram-negative bug right here, bacteria. And you can see the cell wall in the beginning, in the middle, the cell membrane above and below. And when we talk about how do gram-negative bugs get resistance, there are three main ways. Number one, it's going to be pore mutations. So when we talk about these pores, these are going to be like these channels where simple diffusion can occur, and these red dots are antibiotics. So if you have a lot of porins, then your antibiotics get to go inside the cytoplasm. And look at this, there's nothing in there but what? Just ribosomes. So antibiotics, they come in. So what do bacteria do? Gram-negative bacteria, they have mutations to lose the porins so antibiotics can't get in. What's the second way you can do it? Right here, there's beta-lactamases, and it's right there in that cell wall. So when a beta-lactam drug comes in, these beta-lactamases destroy the drug. What's the third way we can do that? is going to be these efflux pumps, the third way you can get resistance. So what do these pumps do? Just like it says, E stands for exit. So when the antibiotic is in, these efflux pumps will pump out all the antibiotic. So how do bacteria develop resistance? They have overexpression of these efflux pumps. So immediately when the antibiotic comes in, it gets pumped out. So when we talk about, what's going to be a great medication, antibiotic for a gram-negative, you want to address a lot of these. So when we talk about terminology, like in this vignette, ESBL, CRE, what do these things mean? So ESBL stands for extended spectrum beta-lactamases. And really, to kind of simplify it for the boards and clinical, just means you're really resistant to what? Cephalosporins. When we talk about carbapenem resistant Enterobaceae, that's going to be CRE. Well, there are two main ways to get CRE as far as genetics. One of the main ways is you have KPCs. That sounds to Klebsiella pneumoniae carbapenemase. And that's about almost 90+% here in the States. But if you go overseas, or say in Asia, the way they have it will be through these things called the metalloproteinases, something that we refer to as the New Delhi strain. But in the United States, we definitely worry about KPCs, which is how they get this carbapenem resistant Enterobaceae. So the last thing I want to mention is this thing's called plasmids. Now, just to mention, when we talk about plasmid, that it's an area that contains DNA separate of the main DNA of the bacteria. And this DNA can actually be translated into protein. And these plasmids, in gram-negatives such as Pseudomonas, can definitely cause another mutation called the AMP-C mutation, which is how Pseudomonas gets their beta-lactamases. So, as I mentioned already, CRE, largely because of these KPC producers. I mentioned already that in the US, greater than 90% of people who have CRE is secondary to KPCs. And when I wanted to mention, so if you have someone that has ESBL or KPCs, well, why are we only focusing on, beta-lactam medications? Well, there are other medications we can use, and let me just mention it. Aminoglycosides, or polymyxins. And do we commonly use those drugs in the ICU? Are those the right answer on the boards? Probably not. And the main reason is what? Toxicity. So there are other options there, but they have so many toxicities. We don't use polymyxins. We don't use aminoglycosides when we talk about these gram-negative bacteria. So really, after all this, what does it really come down to so you get the right answer on the boards? So when we talk about what are the answer choices, what is ceftolozane, tazobactam, Zerbaxia? It got the FDA approval for Pseudomonas. It's a great anti-pseudomonal drug. It works on what? The porn mutations, the efflux pumps, the beta-lactamases, and it got FDA approval for Pseudomonas in the urine, abdomen, and lung. Now, when we talk about meropenem vaibobactam, Vabomere, which was one of the other choices there, it actually got the FDA approval for CRE, secondary to KPCs. Doesn't surprise me because that's the majority of what we see for CRE in the US. And it got the FDA approval for UTIs and pyelonephritis, but when you read the labeling, but not for Pseudomonas. And we'll talk about that in 1 second. Then we have another thing that I put it here because many people ask me about this, something called ceftazidime, which is a third-generation cephalosporin that already covers Pseudomonas, combined with avibactam, and we call that Avacaz. And this got the FDA approval for ESBL and CRE of the urine, abdomen, and lung. It definitely covers Pseudomonas, but probably not going to be the big gun Pseudomonas compared to Zerbaxia. So it really comes down to Zerbaxia, Pseudomonas, Vabomere, CRE in the urine, not secondary to Pseudomonas, and Avacaz, you definitely could think about it for CRE and ESBL. It does have a little overlap with everything, including Pseudomonas. So back to the question. There was a question there. So in this person that came in, we're not going to read the question again, has all these risk factors. What is the right answer? And I wish I could just look at you. I wish you could just send me the right answer. But the right answer is going to be what? Yeah, Cefiderocol. It's going to be D. So let's talk about why it's not going to be the other ones, and let's talk about why Cefiderocol is going to be the correct answer. So when we talk about Zosyn right off the bat, let me just kind of break this down before we go to my teaching slides. Now, Zosyn is not going to be the drug of choice for ESBL. It's not going to be the drug of choice for CRE, so going to be the wrong answer. Zerbaxa definitely covers Pseudomonas extremely well, but Zerbaxa is not FDA approved for, CRE, which is what we were worried about here, because this patient was meropenem resistant, so already taken off. Meropenem and Beta-lactamase, well, definitely covers CRE, but it covers CRE secondary to what? KPCs. Definitely doesn't cover CRE secondary to things that you can get in Asia, like what? That New Delhi strain. And that's where the epidemiology kicked in. Also, this patient already grew Pseudomonas. And what did I say? That Vabomere, when it got the FDA approval for gram-negatives in the urine, it really covers E. coli, Klebsiella, but doesn't cover what? Pseudomonas. And it's weird because everyone's going to say meropenem covers Pseudomonas, and it really does. And it just so happened that Beta-lactamase didn't make meropenem a better anti-pseudomonal antibiotic, so it just didn't get approval for Pseudomonas when we talk about in the urine. So not going to be C. E is going to be the wrong answer. We're not talking about gram-positive. So by process of elimination, what is this Cefiderocol? So let's talk about that. So I already mentioned why. What do we think about in this patient who has this complicated obstructive uropathy? So of course, you definitely want to, address the hydrolymphosis, address the stone, address the obstruction. And, you want to choose an antimicrobial that really can address many of these resistant mechanisms that we talked about already. So when we talk about beta-lactams, I mentioned already that they will all bind to these penicillin binding proteins. But what are some things that happen first is that they get to go through these porins. They mentioned many of these gram-negatives could have these porin mutations, less pores, the bacteria here in the right, these red dots, can freely diffuse in. So when we talk about these pores where bacteria can diffuse in, I wanted to mention that there's another type of entry system in bacterial cell walls that's somewhat similar to these porins. It's an iron transport system. And yes, bacteria need iron. So when we talk about, and why do they need iron? To grow and everything. So what happens is that there are these iron transport systems that use, more of an active transport, and bacteria actually secretes these compounds called siderospores. Bacteria naturally do that. What does the siderospores do? They chelate all the iron out there and bring it back in to the bacteria. So what Cefiderocol do is that it kind of mimicked, it takes a cephalosporin and attached it to something that mimics these siderospores. So what happens is that Cefiderocol is going to be the cephalosporin antibiotic. It's attached to this kind of iron binding siderospore-like moiety. It will bind all the iron. And what does the bacteria want to do is bring it inside. But of course, what's attached to this iron binding, site is the antibiotic, Cefiderocol, the cephalosporin. So they call this kind of like a Trojan horse effect to do the killing. So when we talk about Cefiderocol, it actually is very stable in the presence of beta-lactamases, including KPCs in the New Delhi strain. When we talk about CRE, it definitely is good for ESBL. It definitely covers Pseudomonas. So of the choices here, based on what we're talking about, the best drug for this patient right here was Cefiderocol. And as I mentioned already, why Zerbaxa wasn't the answer was because of the fact that Zerbaxa does not cover CRE. Why do we use Vabomere is the fact that we're thinking about Pseudomonas and the New Delhi strain because they were in Asia, and you're not going to get coverage over there. So this was actually one of the questions, or a variation of it, that definitely will appear on your board exams And as you can tell, I really wanted to spend a big chunk of time talking about this because I don't know about you, but it gets really confusing when we talk about all these newer, beta-lactam, beta-lactamase combination drugs out there for those resistant gram-negative bugs.